to have you take a look at the homepage for Lifespan. And when this is my to-do page, which is about the grading. It reminds me what to do, but there also the due dates for upcoming assignments are here as well. They're also at the bottom of the syllabus page. So it's always a good idea to take a look at those. Also in the syllabus itself, you can download the syllabus, but I also included the syllabus information here. So you can see today we're February 2nd, and tonight you have 2 things due by right before midnight. A lot of you have already turned them in, and so I've been grading them, but this is your deadline up to. So this is a good place to take a look. I try to keep this up. This requires that I manually update it. But the best place is the assignment. This just gives you an idea. Also remember the slow rollout of the ePortfolio assignment. It's now available. It's due by, I put it here, it's due by February 8th. I didn't have we don't meet on February 8th, so I didn't have a place to put it, but just as a reminder, it's coming up. This is so easy to do. Just do this and get your 5 points. So, and then so on. So this is a good place for you to look. So we'll be starting on, we'll finish up breastfeeding today, and then we'll start either today or next time on infant and toddler nutrition. So we can go to the breastfeeding module. And I hope you've had a little bit of opportunity to look things over. This is, again, the sort of splash page for the information about breastfeeding. And I've already shown you several things that we have here, videos and some links. And I'll show a couple of these today since it seems to be working okay. And I'll start out with one that's kind of fun. Where are you? I practiced this right before class. Yeah, here we go. It's about normalizing breastfeeding. I meant to show it on the first page, the first day, and I didn't do it.
What you doing, Buffy?
I'm feeding the baby. See, he's drinking milk from my breast.
Oh, that's a funny way to feed a baby.
Well, lots of mothers feed their babies this way. Not all mothers, but lots of mothers do.
Oh.
Yeah, he likes it because it's nice and warm and sweet and natural. And it's good for him. And I get to hug him when I do it, see.
Oh. Well, is that all he ever needs to eat?
Well, at first, when he was just born and very tiny, this is all that he wanted and all that he needed. But now that he's getting bigger, see, I mash up fruit and vegetables and sometimes a little bit of meat. And as he gets older, he'll need more and more different kinds of food to eat. But for right now, this is just fine. He's drinking his milk.
You know, that's nice.
I don't know why I like to show that. I just do. I think it's kind of fun. Okay, so it's a video for normalizing breastfeeding. The quality is not all that great, but so the next thing I want to do is go ahead and take off from the lecture and then show you a few things. So we left off last time right here, and so we talked about this, about the first experience and how all the business end of this. If the baby's fine, the business end of the shots and everything can happen after the first feeding. Some hospitals still take babies and they wash them. So they take a brand new baby and sort of, it looks like a car wash to me. They take them in and they scrub them down, they put clothes on them, give them the eye ointments, give them the vitamin K shot, and then wrap them up and give them to mother. Okay, that's not a breastfeeding friendly way to handle this because the infant is, if the infant's just put on top of mom, it's got that quiet period, and you saw with a breast crawl how they're able to go up and feed. Another thing about this is the development of the microbiome. Studies show that a lot of the microbiota that gets transferred to the infant occurs during the birth process and also during these first hours. So what the baby consumes is going to affect the first development of the colonization of the gut from bacteria. So this is what we want to try. And then of course, not using formula because that can interfere with mom's milk supply and also with the baby's ability to learn how to feed. But if formula, if it doesn't go beautifully, that's okay. There's lots and lots of time to catch up. But this is the ideal. Now, we mentioned last time that this lecture has some practical information and then also information about policies. And so every organization across the world and in the United States and across the world supports breastfeeding. And support should be everywhere, culturally relevant, targeting families, community groups, healthcare workers, employers, formula industry. This support for breastfeeding should be everywhere. And of course, we talked about last time how moms often don't have choices because they don't get much of a maternity leave. And we are the only developed, if you can use that term anymore, industrial nation where mothers do not get a guaranteed maternity leave. Some companies let them do that. And of course, the father should have leave too, and some companies do that as well. But we don't. We're the only industrial country that doesn't do that. So, but we do have support for the Surgeon General's call to action to support breastfeeding. This is a major focus. This is what, 10 years ago. World Health Organization has something called the International Code of Marketing Breastfeed Substitutes. I'm going to show you that in the next couple of slides. And there's also something called the Baby Friendly Hospital Initiative. And also in Texas, we have our own version of it. And this is an initiative that absolutely helps that first experience when the baby is born in the hospital and the fostering of breastfeeding, and interferes with formula being marketed. So I'm going to talk about a little bit more of this on the next couple of slides. The World Health Organization Code of Marketing of Breast Milk Substitutes. I mentioned this before, but let me talk a little bit again about why we have a code. And the reason that we have a code is because formula industries in the 50s and again in the 80s in particular targeted women in poor countries with little access to clean water and facilities to make clean water, and also sometimes lack of literacy. They targeted the hospitals and the doctors and the families in order to develop a dependence on infant formula, and the deaths were out of control. Third stage malnutrition was a problem, and then the infants would die. And when they, in places like Manila, for example, when they took back charge of breastfeeding, then all of a sudden the infants started surviving more. And so we know that it is completely wrong to market formula to in countries where the water is not clean. It's not proper to do it anywhere because infants do better with breastfeeding, but it's life and death in many countries. So the World Health Organization has this code, and I just kind of want to go over this with you. No advertising of formula to the public, no free samples to mothers. You can't promote the products to healthcare facilities, and no fake nurses that company used to have mothercraft nurses that would advise mothers to try formula. Can't do that anymore. No samples or gifts, and no words or pictures idealizing artificial feeding. And this is really a big deal because the Gerber baby and babies like that looked all plump and healthy were used to market to societies where literacy wasn't that great and they didn't have an understanding for how to keep water sterile. And everything should be honest, scientific, and factual. And any information about formula should also explain the benefits of breastfeeding and the costs and hazards associated with formula feeding. And unsuitable products should not be promoted. Condensed milk will kill an infant, so will plain cow milk. So in order to survive, they must have, it's either breast milk or a substitute that's a formula that's made for infants. And all products should be high quality and should take into account the storage condition and where the country where they're being used. So about 800,000 children's lives would be saved each year if they were optimally breastfed. I don't have a slide on this, but there's also across these nations, there are people that are watchdogs for violators of the code. And I used to read the handout came out every year, or a book came out every year, and they would take pictures of Nestle and some company and how they were marketing. And so there's a way to see what's going on here. And so many countries have adopted this code and they're really serious about it. The United States, we don't have teeth in it, but we do recommend that, or let me put it this way, the major formula industries have agreed to not market directly to the public infant formula without talking about breast is best. Which you might notice, if you look, I don't ever watch TV anymore, but if you look at commercials, what they do now to get around this is they do a lot of marketing for toddler formula, which is for a kid after the age of 1. Now, that's an absolutely unnecessary product. Infants need to, if they're formula fed, they need to stop at a year, and then they start eating, drinking cow milk, but also not in huge volumes, but consuming a wide variety of foods. So that's what's recommended. and they don't need these concoctions for ages 1 to 2. Toddler formulas are a great way for the industry to keep on getting money from parents, but these are sweetened products that can displace healthful foods in the diet. So anyway, but you'll see those advertised, and that's one way they can do this.
I have a question, because there's some children, such as my child, she just has an intolerance to cow's milk. So what, instead of something like toddler's milk, which would, I guess, in some cases be an alternative, what is another alternative that is recommended in place of that?
Okay, when we get to the complementary feeding period, I'll talk about what do we know specifically about dairy. And one thing to know, so we'll get to this, but one thing to know is that we don't have a biological requirement for milk from any mammal, right, after the age of 1. So you can choose cow milk. If cow milk doesn't work, you can choose soy milk. You want to have an unsweetened product. You don't want to offer anything sweetened, and so that gets, these toddler formulas are sweetened, and they're unnecessary. And so they can even be linked with to consumption of too many calories. So you can use something, but we don't need to fill up on animal milk after the age of 1. A variety of foods is fine. So if you want something to get your cereal wet, you know, use oat milk or soy milk or something like that. But, you know, there's not a real need to consume large volumes. We've just been marketed to pretty heavily. I mean, I can remember from the time when I was a child, we had 4 food groups and then 6 and all this kind of stuff. And dairy's always been front and center, but they've had a pretty good marketing plan. They're in the dietary guidelines forevermore. So anyway, we'll get to that again.
Okay, thanks.
Yeah, thanks for asking. Okay, so the Baby Friendly Hospital Initiative, I mentioned this. This is a phenomenal initiative where you take good ideas and support and you turn them into policy to where you can actually make a difference. And so this initiative was set up in order to allow hospitals to adopt 10 different steps and then get the designation of being baby friendly. It was started in 2007. I'm going to show you the website in just a second. It was started quite a while ago, and now 28% of births, over 1 million babies born each year in more than 600 baby-friendly facilities in the US. So this is becoming more and more common. All right, so what is it? It's a hospital that follows these tenets. They have a written breastfeeding policy. Everybody knows about it. They train the staff. They inform, sorry, that should say inform, I apologize, all pregnant women about benefits and management of breastfeeding. They help mothers initiate that breast crawl within the first half hour. They show mothers how to breastfeed. And so oftentimes lactation consultants will come to the room and help her figure it out. They'll have pumps to get her started. And also give newborns no food or drink other than breast milk. This is something where they used to, and I mentioned this before, where they used to kind of break the cycle of breastfeeding by giving them a bottle with glucose water, something like that, and it's not recommended. Allowing rooming in, so they're there. Encourage breastfeeding on demand whenever the baby seems like it's starting to root around, that's the time to start. No artificial pacifiers. This isn't permanent, this is in the hospital. Once breastfeeding is established, let's say 3 weeks, pacifiers are fine. Some families, I mean, you don't want to start a habit where the kid is not happy without a pacifier all the time, because they can, you know, if they grow old and use that, it can interfere with their structure of their teeth. But there are some processes that parents go through with sleep training, for example, where they can use a pacifier only to help them go to sleep and teach them how to go to sleep. My grandson's doing this now. He's 9 months old, but since they did this at night, starting at a month, put him down and they called it his binky. They held it in his mouth, laid him down, you know, flat on your back, which is how babies are supposed to be fed, sleep. And then fed him with give him the pacifier so he'd suck on it. And then he got used to it. And then then they would either leave him or put it back in sometimes because he would cry because it was gone. But then now he's old enough where he wakes up and he looks around if the pacifier's in there, and he'll pop it in his mouth and go back to sleep. So he's a 12-hour night baby, and that using a pacifier was a way to help him get there. I'm not recommending it necessarily. I'm just saying it's okay once breastfeeding is established. It can be used for things like that. The last one's a little harder, and that's to have breastfeeding support groups for people. And this one's just harder for hospitals to do because this is going to take money and resources. So anyway, let me stop here and show you a couple of websites. I have them up here. Here's the baby friendly, can you still, y'all can see my screen, right? This is the baby friendly hospital initiative, just so you can see where this is. And this gives that, it started in 1991, sorry. And this is showing you what has happened to facilities since 1991. It's gone up to, right, 2019. So more and more facilities are up to 600. And this is babies born in these facilities. And so the philosophy is human milk through direct breastfeeding is the optimal way. Precious first days of the birth facility should be protected, and every mother should be informed. So it's pretty nice. It's a policy that makes a difference. Here's another site. This is the Texas 10-step. For some reason, we in Texas, our legislators want us to be different than the rest of the United States. So this baby friendly hospital initiative is international and across the US, but Texas has their own, and it's basically the same thing. It's the Texas 10-step, but it's each one of these is similar to the tenets that are here. Now for a support group, I don't have a slide on this, but I thought I'd tell you about this. This is really, really remarkable. This started in the UK many years ago in London, where mothers were decided to breastfeed together, new mothers to form groups. So they had peer support to breastfeed together. So what sprung up in the UK with places called baby cafes. And they would be in places such as a church that was empty during the week, or some early morning restaurant or something like that, where people could gather, and it's free. So people could gather together and then be with other mothers who are in a similar life stage, and they would breastfeed together. And it wasn't it wasn't medical care, although sometimes there's a lactation consultant, but it was a way to have this camaraderie and go, well, what worked for you? What worked for you? That's an example of peer support. And we do so much better with peer support than when we feel isolated. The WIC program in the United States also has a peer education component. So women who have successfully breastfed and been part of what can sometimes serve as peer support for other people coming in. So that is a Texas 10-step, and you can find, let's say we pick Austin, find a facility near you. And here's places that are follow the Texas 10-step. So the Texas 10-step, I just talked to you about that. So it's the same thing. Okay, so what to look for. At the breastfeeding, we talked about this. Infants know how to do it, but they're not very good at it, and they need help, and mothers need training because it's not necessarily natural to do this. It takes some training. We've always had women around us that have been able to help us learn how to do it. And then right now our society is a lot more isolated, so that doesn't exist so much anymore. So sometimes people feel they're on their own. Social media can help a lot depending on your resources. So if you go to good sites, CDC, WIC, places like that that have valid information, then that's a good idea. There are some sites, y'all know that misinformation is one of the biggest problems we have in our nation right now. So people need to be careful about where they get their information. Okay, so what you want is frequent feedings, at least 8 times in 24-hour periods. So people get really tired of being pregnant, and then once when they have an infant, they don't really get to sleep very much anymore. And they sleep in 2-hour increments. And I can remember hallucinating after my son was born, because I'd wake up and I wouldn't know what was going on, because it's really hard. It's really nice to have a partner that can help bring the baby, change the baby and bring the baby to mom, and stay up and make sure that the breastfeeding happens. And you don't want to lie down on the bed, because there's possibility for the infants to be suffocated. So they really need to sleep in a bed. They can sleep in the parent's room, on their back, or in another room. If they have these contraptions called owlets now, we can put a little brace on their leg, and that'll tell you if they stop breathing. So people have that comfort. But what you look for is a rhythmic suckling and audible swallows, and you can watch that. Now I have a diaper here because a lot of these newborn diapers have a water indicator or fluid indicator on them. So that's a blue line there. And that's a way to tell, because sometimes the urine volume is so small, and you get the diaper and you look at it and you go, I'm not sure. So this has an indicator, so you can start kind of keeping track. There's some nice apps out there that people can keep track of breastfeeding, and then also keep track of the feedings until things get going. And once you're done and breastfeeding is going on, there's no reason to keep writing all this down. But at first, especially in the first 2 weeks, it helps to have a clear picture of what's going on so you can communicate with any healthcare providers. Okay, so they should have at least 1 to 2 wet diapers in the first 2 days, then 6 to 8 every 24 hours after that. And they'll have transitional stools, and then they become yellow by day 4. An interesting thing about breastfed babies is this is actually kind of nice, is their bowel movements don't smell very much. If it's a fully breastfed baby, then it doesn't have a very strong aroma, but once once they start eating food, then that's all over. And then it depends on the person and their microbes, but so they're often really loose. Breastfed babies' stools are often very loose. Sorry. Okay, and then after day 3, they should start having bowel movement. So this is kind of how you tell what's going on, but then you always go to a healthcare provider, like on day 3, they'll weigh the baby and they'll check for PKU and conditions like that, and make sure things are going okay, talk to mom, make sure that the feeding is going okay. And then after 2 weeks, you go in again and they weigh the baby. And there's always going to be weight loss after birth because they're waterlogged when they're born. They've been floating around in amniotic fluid, drinking amniotic fluid, and so they're sort of waterlogged. And then after they're born, then they don't have as much coming in from the placenta, and so every calorie has to come in from their mouth. And remember the tiny volume, so they're naturally going to lose some weight after birth. And for the next, but the idea is you want to have be back to birth weight by 2 weeks. Not every baby does that. Sometimes that's fine. If these indicators are there, it may just be a baby that's slow to come back. But this is more of a medical issue. I just kind of want to give you an overview of it. Any questions before I move on? I'm going to talk about latching and positions and all that. Okay, so some challenges in how to go about breastfeeding. We've talked about the latch, so I'm not going to show you the video anymore, but we've talked about how this happens. And so this is the correct latch position. And the difference between if they're doing it wrong, then of course it can cause pain and milk won't come out. And if they do it right, then milk does come out. So that's important. Improper latching is a big problem. The causes can be poor positioning, not holding the baby just right, not facing the mom. And also there's something called tongue tie, which I'm going to show you. And also lack of a wide open mouth. So mom has to insist that they open that mouth really wide and not let it get used to having a small mouth because it can cause a problem. So what happens if there is improper latching? Then there's sore, cracked nipples, pain. She may develop mastitis, and I'm going to show you some images of mastitis that'll make a believer out of you. And then also it can end up with breastfeeding cessation, even though mom wants to do it. Solutions: skin-to-skin contact, frequent latching, and the use of nipple shields. I'll show you a picture of that in a minute. What you want to do is train the infant to open their mouth and make sure the nose is free from the breast. And you can see areola more at the nose than at the chin, and healthcare providers can help people get started with this. That's what a nipple shield looks like. It's a plastic thing that mom can put over the nipple, and this can happen if she just can't get her act together and she's panicking and it's day 2 and she wants to make sure this goes. Sometimes they'll use a nipple shield for a little while because it's easier to get the milk flowing and then transition off of that. The positioning is critical. Mom should be comfortable, and there's all kinds of comfortable positions here. The cradle hold, notice the baby's facing her. Cross cradle, she holds the baby across a little bit different, and then lying on your side, and a football hold, and laid back hold. Now, you may wonder why you have these different positions. Sometimes it's easier for the infant to empty different parts of the breast if the position has changed a little bit. So you don't want milk to stay in certain lobules for a long period of time because it can lead to mastitis, which is an inflammation of the breast. So these positions, and doing this though, you want to be careful and have somebody watch in case you go to sleep, especially because people are so tired right after birth. This is the tongue tie. I'm going to show you a quick video of this. I'll show you a picture. Tongue tie. Yeah, here's the image. Okay, tongue tie looks like this. Now remember what the latch looked like, where the tongue had to be coming out. And some infants though have a frenulum, which is just a little flap of skin that look, their tongue is kind of heart shaped here, right? And so it interferes with the tongue being able to work on the latch. And some mothers just can't get this going. And these can be associated with problems with speech later on in life. And so, this is a medical choice, and so I'm not competent to make this recommendation, but often people will go to, and usually it's pediatric dentists that handle this, and they'll laser cut them. And so they can laser cut them, and then that can free it up. And now it tries to grow back together because it's a wound and their mouth is shut. So you have to keep stretching it out a little bit, which isn't that much fun. But then it's done, and then they can nurse, and then the latch is fine. So I want to show you my, I've already looked at the latch, so you can see that on your own. Yeah, this is age restricted, so.
In order for effective breastfeeding to occur, a good latch is required between the infant mouth and the breast. An effective latch requires a few things from the infant. The mouth is widely open with lips that are flared or curled out. The tongue is extended over the gum and under the nipple. The nipple needs to be fully inserted into the mouth, including some or all of the areola. If any of these factors are missing, breastfeeding may become ineffective. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling and gas pains. A normal infant tongue has good mobility. Tongue tie is when the tongue is stuck to the floor of the mouth, preventing adequate mobility, which leads to an ineffective latch. The tongue tie may also be hidden under the mucosal lining, a condition called posterior tongue tie. With tongue tie, the tongue tip does not extend over the gum, causing the newborn's gum to chew on the nipple during feeding. Also, the up-down motion of the tongue is hindered, preventing an adequate suck, resulting in decreased milk production. A surgical procedure called tongue tie release can easily correct this cause of ineffective breastfeeding. Upper lip tie is when the newborn's upper lip does not curl up or flare out enough, resulting in loss of suction and the nipple to be incompletely engaged within the mouth. A surgical procedure called upper lip tie release can easily correct this cause of ineffective breastfeeding.
Okay, videos are always a little more helpful. So I've already showed you the slide, sorry. Okay, now let's talk about mastitis. And I mentioned this is inflammation of the breast. And what are causes of mastitis? It can run in families, sore or cracked nipples. You know, for a woman that's never breastfed before, sometimes the first getting started is really hard and people want to give up. Sometimes they may get hurt and they're tired and formula seems so easy. And so they're at risk for stopping. They may start, their nipples bleed and they're thinking, I can't live like this. Often by the age of, after the infant's about 4 weeks to 6 weeks, it's a fabulous process. Mom's completely happy. She doesn't have to worry about formula. She can take the baby anywhere with her, and breastfeeding is a snap. But people need to know it's not a snap right at first, and that some of these things happen, but they can be fixed. So mastitis is no fun. This is one thing I had one time, and I woke up in the middle of the night. My son was, I don't know how old, I don't even know, an infant, and I woke up with a fever, and I hurt so badly that it felt like I'd been kicked 100 times. I was in excruciating pain. It took me forever to sit up out of bed and go find my partner and say, we got a trouble here. Okay, so it's not fun. Some people keep getting it, some people never get it. So causes may be just that attachment issue, the poor positioning. Mom may be engorged right at first. We talked about how that can happen. So all the things we've been talking about can contribute to this. That's why you want to solve them. So the problem's pain, and without taking care of it, mom can develop an abscess and actually have tissue split. And then she doesn't want to do this anymore. But it's very fixable. Improve the techniques, rest, Mom needs someone to help her at least the 4 months of life so she can rest, develop this relationship with the baby and take care of things. Warm packs, getting into the shower sometimes can help relieve some of the pressure. And then last but not least is antibiotics. Antibiotics are going to take care of the bacteria. And so what we want to do is get rid of the bacterial infection. I took antibiotics and within 48 hours, I was completely fine, but those 48 hours were terrible. And what's interesting is you're supposed to keep breastfeeding the baby from that breast, even though it's in pain, in order to keep removing milk from it. And you may think, well, is that bacteria bad for the baby? It's not. The baby doesn't get sick from that. It's just a natural process to remove it. So that's what people do with this. And just to entertain you, I'll show you a couple images of mastitis. It's not very entertaining, really. They're pretty awful, but we're learning, so let's do it. So these are photos. Yeah. Okay, so here's a photo of mastitis. See the red area in her breast right there? Here's another one. It's red all the way around here. Now, sometimes people get nodules and it seems hard. They can often work those out and massage them a little bit. They don't become infected, but this is when you have an infection. So, yeah. Anyway, you can see why this is a hard one for moms, but also there's solutions. I don't know why I keep doing this. So, okay, another problem is low milk supply, and let's be careful about this. Causes can be a poor latch. Notice how that keeps coming up. Infrequent feedings. Some babies sleep too much when you want them to sleep, but they sleep too long, too early. A couple-week-old baby doesn't need to be sleeping for 5 hours at a time unless it's gaining well. But if it's not gaining, then what you want to do is wake it up, and sometimes wake it up really well, take its diaper off, get it cold or whatever, and then breastfeed it so it gets enough milk. But because also mom's establishing her milk supply, so she doesn't need to go for a long period of time at first without breastfeeding. So remember we talked about the amount of milk produced is based on how much is removed. So if we stop removing milk, not as much is going to be made. So it may seem counterintuitive to people, but if they feel like their milk supply is low, hooking up to a pump after feeding, so feed the baby and then pump. And sometimes people can pump a couple of times and you think, oh, there won't be any left for the baby, but there is. And it's also signaling to the breast, make more milk. So there's strategies that people can use to keep up their milk supply. Occasionally, there are women that don't have all the mechanics needed to breastfeed. It's rare, I mentioned this earlier, but it's possible. So if their anatomy doesn't produce milk, we're done. That's what formula is for right there. And then this last one, I really want to highlight this. Many women feel like they have insufficient milk when they don't. It's very easy to feel this way, to feel inadequate, to feel pressure. And as long as the baby's growing, which is why you need healthcare providers to help you take a look sometimes, then it's fine. And if she can get at this with some positive support. So, but if there is actually, so it's rare, if there is actually a low milk supply, the infant's not going to grow, mom's going to stop, and then she's going to, end up with formula. So what do? Monitor them. Have a lactation consultant if you can. Empty breast fully at each feeding and watch to make sure they're swallowing. Everybody grows at a different rate. We'll look at growth charts in the infant presentation, and you guys have had experience with that anyway. So, but infants grow at different rates, but they do need to be gaining weight. It's a red flag if an infant's not gaining. So let's look at the reality of this. The perception of insufficient milk. Only 2 to 5% of women are physiologically incapable of producing adequate amounts of milk. Okay, just so you know, from what I can tell, that is a made up number. I see it everywhere in the literature. People say this all the time. I don't really know how valid that number is, but you're going to see it. But the idea is that most women can produce adequate amounts of milk, and that's true. But the number, I'm not sure if this is perfect. And however, compare that small number to the number of women that perceive that they don't have enough milk. They perceive insufficient milk. And then once she feels that way, start offering formula. The baby's gonna remove less milk, and then she's gonna end up losing her milk supply. And this should be addressed in education in such ways that people understand that babies are not, the behavior and the growth of babies is not written in stone, and they probably do have enough milk. If you have access to healthcare, which is the biggest issue here, going to a lactation consultant would be so helpful. The women go there, they have the baby, the lactation consultant will watch them feed, weigh it before and after with no diaper on, watch it feed, see how much milk is being transferred, and give recommendations on positioning. And this can make a world of difference for people. But Texas is, I think we have less access to healthcare than any other state in the nation. And so this is, in many cases, a luxury for people. Barriers to breastfeeding, we've talked about this: school, work, fatigue, medical conditions in some cases, a lack of support or that perception of insufficient milk. That's a big one. And it's interesting, there's some demographic characteristics of people that are less likely to breastfeed. It's associated with age, education, health, income, and also race, ethnicity. And what this has to do with, to the best of our understanding, is that the opportunities people experience in the healthcare situation are very different. All right, so we have, in our country, we have races that don't feel, Black in particular, that don't feel that they can find healthcare providers that are like them, that understand them, and feel marginalized. And so sometimes this help that is definitely needed, there aren't the resources for them. So it's also what's common practices in the family. So that's why the Sesame Street stuff and the little kids breastfeeding and so forth can, their dolls can show that people that can help normalize it. Okay, now we keep track of how many people are breastfeeding. Data is collected every year on this. And so the Centers for Disease Control and Prevention, they have a report card. I have a link for that if you want to look at it. And I won't ask you any of these, I won't ask you any of these numbers or anything like this. I just want you to kind of see what they do. They have objectives. They want to have more kids, infants who are breastfed ever. So here's the target, here's the rate. So we're actually doing better than that. So this means the infant is put to the breast at least once. So often in a hospital scenario, someone may put the infant to the breast and then never do it again, but they get counted as at least some exposure. And this is proportion of infants who are breastfed at 6 months. Not doing horribly here. We're not quite at the target. So you can see then they look at 1 year, exclusively for 3 months, exclusively for 6 months. And you can see here that we have, this is pretty good, and we have some work to do because we'd like to see that at 90%. So, and this is more about policies, but I won't ask you these questions like what's the percent. I just want you to know that this information is available. Now, not everybody can breastfeed, and there actually are, besides potential for her not having the adequate lobules for forming milk, there's a couple other things. There is a condition called galactosemia. It's a genetic condition in which an infant is unable to digest galactose. This is a very serious condition that can be fine if caught and treated. This is one of the first things infants are tested for. If they do have galactosemia, then they can no longer consume lactose in any way, shape, or form. So that means they can't breastfeed or consume cow milk formula. So then they would be given a soy milk formula. All right, so that there would be no lactose. If they don't have any lactose, then their prognosis is great. But if they do have lactose, then and they continue to consume it, then it causes severe mental handicaps. It's a serious problem. So you can't breastfeed if an infant has galactosemia. Also, if mom is HIV positive in the United States, infants do better by not being exposed to HIV through breastfeeding in the United States. However, internationally, in countries that have fewer resources, and including poor access to clean water, infants do better if they are fully breastfed, never get any formula, even if mom is HIV positive. They're less likely to get HIV than if they're mixed fed. So it seems jarring, but it's actually true, because formula feeding is with bad water quality is very lethal. Now, there may be some cases where she shouldn't actually nurse directly. If she has tuberculosis, herpes lesions on the breast, if some people have this and she can wait till they go away, she can pump during that time. If she has chicken pox, she can pump during that time. And if she has a flu, same thing. And this just sounds awful to me, to have the flu, have a fever, and not be able to nurse a baby and have to be pumping in order to get through this. Is very hard for moms, but this is the recommended plan. For COVID, she should nurse and wear a mask. So that's the current recommendations. In particular, because the immune components offered by human milk that we've talked about can make a big difference in survivorship and in infection from COVID. And I don't know enough about exposure of infants to COVID and what all that entails now. I do know that there's some problems. If mom has COVID during pregnancy, sometimes she has trouble with hemorrhaging during the birth. So that's a problem, but I don't know enough about what happens to the infant, but these are the current recommendations. Okay, I'm going to pause here for a minute because the next thing I'm going to talk about is alcohol and breastfeeding, but I want to know if, I know I'm talking a lot, I promised I wouldn't do that. Do you have any questions?
I have a question. For the tongue tied, sometimes some infants get that on the top or on the bottom. Would you know, do insurances cover that surgery, or is that considered more of like an optional, maybe like a luxury?
I wish I could give you a good answer for that, and I don't know. Which is interesting. My son-in-law is an actuarial person that works for an insurance company and does all these plans and stuff. And what I know is that it depends on the plan, probably, right? So, and you know how insurance companies are, they say they're going to cover everything, and then when you get down to it. So I don't know. It's a really good question. I don't know if I mentioned that pediatric dentists are the ones that do this. I don't know if I said that, but they're the ones that do that. Anybody else?
Yeah,
I
could
was
you
just
go
wondering
over?
about sorry, go ahead.
Oh, I was gonna say, could you go over the insufficient milk again? You said 2 to 5% is like the normal number that's quoted, but you don't even know where they got it from.
Yeah, what I mean is I see that all over the place.
Mhm.
So it's commonly stated, but I don't know if there's been an actual study. Think about how to do that well, right? So let's say you have 1,000 women that are all intents and purposes are going to breastfeed. And so they all try to breastfeed. And so I don't even know if that sample size is large enough to tell this. You may even need 5,000 or 10,000 in your study. I don't know. It depends on what they're looking for. Then they would have to look and see what was affecting breastfeeding, and then look at the breast to see if they're actually producing milk. And so this isn't done on a national basis, right? So the women that have trouble breastfeeding sometimes keep trying it, and the kid starves, or they try and realize they're not making enough milk. And it could be due to the structure, but it could be due to other things as well. So it's just complicated. That's really all I have to say about it is I'm not sure of the number. I'm just telling you what everybody says.
Okay, thank you.
Yeah.
I was just gonna ask about like women who suffer from postpartum and how that affects breastfeeding.
That's very interesting. There's actually studies that show breastfeeding can help her with postpartum depression. And, everybody's different, but there's literature on that. Thank you. This is a really good question. Okay, everybody's always interested in the alcohol piece. So let's take a minute to cover this. So let's talk about the concerns first. And just so you know, my lecture on this has evolved year after year after year as we learn more and more and more about breastfeeding and alcohol. But just so you know, we can't do the study, right? We can't do an experimental design where you divide breastfeeding women into 2 or several different groups and have them consume different amounts of alcohol, see what happens to breastfeeding and see what happens to the infants, because that's not ethical. So we can't actually do the studies. So what we have to do is look for correlations. And so these studies about alcohol and breastfeeding are interesting, but no study stands alone. So sometimes a new study will come out and it will say, hey, it's okay to breastfeed these kids after 5 years, are fine. And then another study will come out with a different design and say, hey, here's some problems with math function, right? And so no one gives alcohol a clean bill of health. Absolutely no alcohol during pregnancy. Absolutely, we'll talk about that later. I'm talking about breastfeeding here. Okay, so this is after the baby's not hooked up anymore. And so what are the concerns first? And then let's talk about what practical advice exists. The concerns are, remember the hormones prolactin and oxytocin? Prolactin is involved in producing milk, and oxytocin is involved in milk ejection, right? And contraction of the uterus, right? And so the prolactin is needed to stimulate synthesis of milk. And regular alcohol consumption can interfere with this action, so it will depress her milk supply. So that's one thing to consider and may decrease her ability to breastfeed. Also, of course, we're all interested in the alcohol content of breast milk and does it affect kids? And many studies it depends on what they're looking for as outcome measures. If they look at height and weight and you go, breastfeeding, alcohol consumption during breastfeeding may not have any effect on height and weight of kids later. But if you look at abstract reasoning or some other type functionality, sometimes people see declines when women consume a lot of alcohol during breastfeeding. So it can, here's one study, it has reduced abstract reasoning around 6 to 7 years in a dose-dependent manner. So this is a study where the comparison group is women who drank the same amount, but were fed formula. So in other words, the drinking in the two groups was the same, but the kids that were breastfed had this decrease in functionality. So that's a pretty good type study, right? Also to keep under consideration that parents who drink too much can't take care of their children. This is how children get dropped. But the real issue is how much alcohol is in breast milk. If it's not in there, if there's a way that you can have a drink and the alcohol not increase the increase in breast milk, then there can be some safety in there. The reason that I say this is because sometimes women think, well, I'm not going to breastfeed for a whole year because I don't want to drink alcohol because, our society is really interested in alcohol, right? So this may stop her from wanting to breastfeed. But what I want to say here is there's a way that these two situations can coexist. Now, she in a perfect world would never consume alcohol. In a perfect world, her diet would be perfect, her exercise would be perfect, and her family structure would be perfect, and all that kind of stuff. And we don't live in perfect worlds right now or ever. But practically, it looks like an occasional use of alcohol may not be harmful. And I'm talking 1 to 2 drinks, not binge drinking and not daily. So Kelly Mom is an organization that pulls together, it's a website that pulls together current literature and comes up with recommendations. And they've been so important because our government has not had any recommendations, official recommendations, until just recently with the new dietary guidelines for Americans. So we haven't had any guidance except from American Academy of Pediatrics or something. So this organization has been very good about giving practical advice to moms about breastfeeding, resources, lactation, and all the pieces. So what they say, mom can breastfeed when she feels neurologically normal. So in other words, if she feels alcohol, then probably the amount in her blood is too high. And now her milk is not going to have as much as her blood does. You need to think about this, okay? So let's say she consumes 2 drinks and her level of alcohol in the blood is this high. The amount that goes in the milk is much, much smaller, right? Because the milk is not the same thing as her blood. There's all this other stuff in there too, so it's way diluted. So they get some. Now, maybe not very much. Now that may seem, well, that's crazy and that's not right, but water can have a little bit of alcohol, or not water, but the natural products can, orange juice can, there's things like that also have little amounts of alcohol. So it's not it's not cut and dried, all right? And so per the Academy of Pediatrics, ingestion of alcohol should be limited to occasional intake, no more than 2 drinks. And nursing should take place 2 hours or longer after the alcohol intake to minimize its concentration. So her blood levels will go up and then they'll come back down. So let's say she wants to drink, she breastfeeds the baby. She's already got lactation established. She's not going to do this very much because it can decrease her amount, but she can breastfeed. Assume the baby's good for 2 hours. I would have some pumped milk just in case it's not, so it can be fed a bottle. And then her the alcohol will be cleared from her breast milk over that 2-hour period. So then when she nurses again, the alcohol level is really low. So we used to recommend that you pump and dump. So go ahead and drink and then pump that milk and throw it away. But that doesn't seem to matter. What matters is waiting 2 hours from the last lactation. The other recommendation is obviously don't share a bed with an infant after drinking, and don't get drunk, and be careful, because if you have a habit here, it can affect infant weight gain. Any conversation about this? It's a lot of information.
Is there a way that we can test if the milk still has alcohol in it after 2 hours?
Yeah, there's little test strips people can get. I don't know how useful they are, but they do exist, and I don't know enough about them to know if they really matter. Good question. So do you have an opinion looking at this? Do you think she should breastfeed? I mean, do you think she should be able to drink? She shouldn't drink? Does anybody want to hazard a thought about that?
I have a comment because I asked my lactation consultant this, and she actually gave she talked about herself, and she said that, you know, when she had her kids, that she would only drink you know, like a small amount of wine, and it was always like during a big meal. So, you know, like you kind of just have to be logical about it and be like, you know, if you feel drunk, then obviously don't breastfeed. But if you have a small amount and you know, you feel normal and you've eaten a lot, then it's just a lot safer. You know, it's just kind of like a use your common sense type of thing.
Yeah, that makes total sense to me. Thank you. You guys may have more to say when we get to the pregnancy lecture. This one is a little less controversial. Mostly it's practical common sense. And if drinking is so important that you need to do a lot of it every day, then there's other issues going on that people need some more care with that as well. Okay, so is it ever a good idea to supplement with formula? Well, remember colostrum, remember that tiny amount of colostrum in the first few days? That's all they need. They're not going to be gaining weight. They're going to be losing weight. That's okay. That colostrum is what they need. So no formula in general, but you do use it if it's medically necessary. Now, when can that happen? Some infants, especially born to obese pregnancy, or diabetes, if mom's diabetic, after birth, the infant at birth, before born has high blood sugar like mom, and then after birth, without having the hormonal regulation and without having a functional metabolism going on, they can develop hypoglycemia and the blood sugar can crater. So some infants they'll check their blood sugar in the hospital. And if it's too low, I think the number is 40, but if it's too low, then they're going to say you need to feed formula. If you can express milk, do that. That'd be great. But if it's just not coming in, then they need formula in order to get past this. That is there's a whole organization out there called Fed is Best. I like their concept because obviously we can't promote breastfeeding if it's not working. We're not helping the infant if we just died in the world. This absolutely has to happen. You know, it's more important than anything in the world. What's more important than anything in the world is the infant gets food and their brains can develop and they're okay. And there are some cases where that's not the case. Maybe not enough milk is being produced, or it's not coming in fast enough, and the infant's blood sugar is going down. In that case, formula. And it's not the end of the world at all. I know it sounds like it when we talk about how important breastfeeding is, but it's not the end of the world. What's important is that they keep their blood sugar up because it can affect neurological development. Now, what they can do in baby-friendly hospitals is they won't use bottles often. They'll use a syringe And so the baby they can put some in the side of the mouth, and that'll help the blood sugar come back up again. And it doesn't interfere with the baby learning how to breastfeed. Okay, so that's the end of this lecture. Go away. And let me see if there's anything else I wanted to show you here. Oh, one more thing. This is another solution sometimes. I'm going to start this in the middle. Sometimes if mom doesn't seem to be producing enough milk, or if the baby's been removed for surgery, or mom's had some medical thing and they've had to be separated, so you can reestablish lactation if it hasn't been too long. And what they do is they use this thing called the supplemental nursing system. And so she talks too long about this, so I'm going to start it and then decide where I want to take off. Yeah.
The breast. This is actually a really, she is in fact trying to increase to make sure that they're getting enough calories to give to her baby. If I'm going to be using today is actually makeshift. These are meant for more temporary nutrition's office, your hospital, or your local lactation consultant. They're not something that you can actually buy directly online. But these are meant for more temporary use. The ones that you can buy that are commercially made are ones for longer term use. What I find can be really helpful is actually attaching this to mom first before latching the baby to make sure that the two little holes that are right here, both of them go inside baby's mouth, because otherwise if you press the syringe and not all the holes in the baby's mouth, it's going to squirt all over the place. And whoever said that don't cry over spilled milk has never come to milk and then had it spill out of the baby's mouth. So let's get this little kiddo latched on because I think he's very hungry. So, well, actually, since he's already latched, one of the other ways that we can actually use this too is inserting it into the baby's mouth when the baby is already latched. So we've got this kiddo already on. We slip it into the top of the baby's mouth, right in the corner, and then either baby can suck it down. There you go, kiddo. Or you can actually put some gentle pressure on it and offer and kind of help them out a little bit. Another thing that can be really helpful is taping it to the breast first. What I like to do is actually tuck this into mom's bra, so that way baby's hand is not getting all over the place. Sorry, baby cakes. Oh, and taping it directly to mom. So where it pokes out a little bit beyond her nipple. I know, sweetie, I'm sorry. And latching him on that way. Then once the baby's latched, mom can then take the syringe out of her bra and start to provide some gentle pressure. And I'll help you too. Providing a little gentle pressure to speed up. There we go. There we go. Awesome job, kiddo. Another thing you can actually do is put this tube inside a bottle as well. If your baby has a really great suction and can pull it right through that tube really quickly, a bottle is really nice because those syringes tend to stick a little bit, and the negative pressure can kind of make it difficult for the baby to pull it out on their own. So that is how you supplement a baby at the breast. If you would like more information or some more videos to watch, you can check out our YouTube channel.
Does that make sense? Let me explain what that was. I think I kind of did that, but in some cases, if the baby's been separated and mom's milk supply may not be up again, what this does is it allows the baby to realize that being at the breast is where it gets fed. So even if her milk supply is not quite caught up yet, that little tube will provide more milk. So the baby is rewarded from a good latch and being at the breast with actually being fed. And the baby's suckling and stimulates milk production by the breast. She's still going to want to pump and everything to get after the feeding to empty the breast as much as possible. But this is, I've seen babies that have had like open heart surgery right after they're born and not be able to be held by mom for a week. And then she can use this system to get the baby to learn to latch. And so otherwise they get frustrated if they have a bottle where it's really easy to feed. They can get attached to the bottle and then they get angry at the breast. So this is a way to kind of get them past that. Any questions about that? All right, well, I think I've told you everything that you might want to know about breastfeeding. I have some information here that supports what we've talked about in the lectures about nutrient requirements and so forth. And I have yesterday's lecture here. After today, I'll post this lecture here. I'm going to take a moment to go ahead and get you oriented for the next module. So the next module is infants and toddlers and allergies. And so this module talks about lots of things like age of introduction, when do you start giving particular kinds of food? Why does the first 1,000 days of life matter so much? And I'll talk about some very interesting things in this lecture about infant mortality and how that is affected by race in the United States, and also provide specific guidelines on what to feed infants, when to feed infants, why to feed them those particular things, what not to feed infants, and so on. And so these look like a lot of resources. I went through them carefully to make sure that there's not too much information here, but it's very helpful. I hope you realize as I show you the films and so forth during class that these aren't a long time commitment, but they can help you understand in a way that's much better than if you just listen to me talk on and on and on. So let's see. So I'm just going to get started for a few minutes on this lecture on infant nutrition. It's posted for you. This is just to get started, and we'll be slow next time. So this is my third grandchild, 3 months ago. I get 3 pictures, so there you go. So this lecture on infant nutrition, we'll talk about assessing infants, and I'll talk about something very disturbing called infant mortality. And we'll bring in health disparity and health equity to understand how the world is a different place for different people in the United States, with respect to healthcare. We'll talk about a condition called failure to thrive, in which some infants don't grow enough. We'll talk about their nutrient needs and give some caution, and then also give you a lecture on infant formula, what's in it, how do you prepare it, how do we know it's safe, and so forth. So you're fully informed not only of breastfeeding, but also of how to feed infants. The lecture after this, we'll talk about those first foods. So this is basically functioning on infants here. So the first part is assessment. And there's something called an APGAR score that infants are given after they're born. So they look for several different things, and APGAR comes from the first letter from each of these terms. So they look at the skin color. Now for white babies, it would be pink. Okay, obviously for black babies, it's going to look different, but you can still see a bluish tinge depending on individuals' lips, regardless of skin color. But you look for the pulse. So you can see you get high scores if you're pinked out, and that means that there's good circulation, good oxygen present. Heart rate, if it's over 100, they get a 2. If it's low, you can see they get a lower score. And so the 2 is the best. And if everything in these categories, irritability, muscle tone, and breathing are good, then they get a 2. And so the total would be a 10 because there's 5 different categories. So in a medical chart, you might see the APGAR score of an infant, and that would be what happened right at birth. And so some infants may have a lower APGAR score because they experienced some trauma during birth. Maybe their heart rate was low. Sometimes birth can take 2 days and the infants can become at risk. And so there's different things that can affect them. So I just want you to know, I won't ask you what these letters mean. I just want you to know that there's a score and what it's for. It's for giving an idea about the health of an infant at birth. Okay, how do we assess infants? This is important. I know when you take a nutritional assessment, you look at growth charts, and so you know how to use these growth charts, but I want to go over the details for how we assess infants here so you're clear on this. We look at growth charts for specific to 0 to 24 months. These growth charts originated now from World Health Organization data, which means that the charts themselves, the standards, are representative of breastfed babies across the world. So we plot a child against that. So we look at the weight for age. You can see that this is actually a bad picture because he shouldn't be wearing a diaper, okay? Because they weigh him naked. They don't like it. They cry on it. So you look at weight for age. That's one assessment. Length for age. Okay, this is measuring the length of a baby. You got to smash their legs down. You have a board here and here. It's called recumbent length. When they stand up and they're older, then that's different. But when they're infants, then you lay them down and measure them. And then also head circumference, which can have some correlation with health and maybe cognitive function later on, but everybody's different. And then you also do weight for length. And this is used later on, not at infancy, but I mean, not in the first few weeks, but later on during development to assess whether or not the infant's growing too much. So here's an example. This is weight for length. It's a World Health Organization chart, but this is also, if you go to our Centers for Disease Control and Prevention, CDC site, and you look for growth charts, these are the charts that come up. Okay, these are the standard charts that we use in the United States as well. Now notice that we have these lines, and I believe you're familiar with this, but just to give you a refresher, this is excuse me, this is kilograms and this is length. And so typically children follow one of these lines. Okay, some kids are at the bottom of the line. Some kids are at the top of the line. Some are kind of in the middle, but normal growth is generally a line is followed. Okay. Now, if infants are above the 97th percentile, we'll talk about this, that indicates that they're too heavy. And if they're below the 3rd percentile, that may indicate that there's a problem with growth. But you have to look at the parents. Sometimes parents are small, so the kids are going to be the smaller ones. So anyway, this is just to remind you what growth charts look like. Now, this may be, I don't know if this is new terminology for you, but it's important that you know this now. These are classifications of newborn size, and we care about size a lot because it has an effect on infant outcomes. One term is called appropriate for gestational age, or AGA. That means they're within normal limits. The size is within normal limits, between the 10th and 90th percentile. Another term, small for gestational age, is when the infant is less than the 10th percentile for age. So here's a picture of a smaller infant. Large for gestational age is when they're over the 90th percentile. So this kind of gives us a way to group infants and look at their potential outcomes based on their birth weight. Low birth weight is less than 5.8 pounds or 2,500 grams. And very low birth weight is less than 1,500 grams or 3 pounds, 5 ounces. Infants that are born at a very low birth often experience conditions called intrauterine growth restriction. There's a variety of reasons this can happen. The placenta may not be attached very well. It may not be very good at transferring nutrients. So issues like that. Smoking can actually restrict blood vessels, and so nutrient transfer isn't as great. So there's a variety of reasons, but so these are terms that we're going to use as we talk about infant mortality, how infants do, what's a sweet spot. Knowing what the healthiest weight for infants is helps us predict how much weight mom should gain. So we have recommendations when we get to pregnancy. Well, how much should she gain? And that's based on having the baby that's the best size, that's more likely to survive and be healthy. Okay, I'm going to stop at this point because this is a lot of information. We're going to start with this lecture again next time. But let's see.